Welcome to the deep dive. You know that feeling, right? Staring at just stacks of information, research papers, notes, and you just wish someone could, I don't know, cut through it, tell you what actually matters, give you that shortcut. Well, that's what we do here. We aim for those aha moments, making the complex stuff just click. Today, we're tackling something huge. How do we actually get ahead of these massive public health costs? Specifically, osteoporosis, not just the condition itself, but the looming financial hit, especially for places like Florida, with aging populations. So our mission today is to really dig into this one specific research paper. It's called Methodology for Estimating Current and Future Burden of Osteoporosis in State Populations, Application to Florida in 2000 through 2025. We're going to pull out the key insights. How did Florida project these costs? What did they find? And maybe most importantly, what does it mean for health policy down the road? If you're interested in healthcare economics or how demographics shape spending, stick around. Okay, let's unpack this. Before this study came along, why was it so hard to get a clear picture of the cost of osteoporosis? I mean, particularly at the state level.
Yeah, that's a great starting point. It was surprisingly murky, and the issues were, well, layered. A lot of it led to underestimating the real burden. One of the biggest problems was just widespread underdiagnosis.
Underdiagnosis, meaning doctors weren't catching it.
Not quite like that. More that even if osteoporosis caused a fracture, it often wasn't explicitly written down in the hospital records. So if you were just counting official osteoporosis diagnoses, you'd miss a huge chunk of the actual costs associated with it.
Ah, okay. So the records showed the broken bone, maybe, but not necessarily the underlying why.
Exactly. Then you've got the whole issue of long-term costs.
Right. It's not just the emergency room visit.
Not at all. Think about hip fractures, spine fractures. There's rehab, maybe stays in long-term care facilities, ongoing support, sometimes for years. Older methods, they often just didn't capture those cumulative ongoing costs very well.
And you mentioned state-level data.
Yeah, that was another hurdle. Data availability. States might have decent hospital data, sure, but getting a complete picture of outpatient care or long-term care costs, specifically at the state level, that was often missing.
Right, like seeing the cost of fixing the immediate leak, but not all the water damage afterwards.
That's a perfect analogy. And finally, there was just a real lack of standardization. Earlier studies in states like Illinois or Pennsylvania, California, they all use different methods, completely different.
So you couldn't compare results?
Not really. Not apples to apples. For instance, one study might say hip fractures were, I don't know, 20% of osteoporosis admissions. Another state, using different criteria, might find it's closer to 70 or 80%.
Wow, that's a huge difference.
It is, and it really highlights the core problem. If you don't actually know the true cost, how can you possibly plan effectively? How do you allocate resources where they're needed most? It's like flying blind.
You really can't hit a target you can't properly see. Okay, but here's where it gets interesting. This Florida study didn't just point out the problems, right? They came up with a new way forward. So how did they manage to cut through that fog? How did they build this clearer picture?
They took a really smart approach, kind of innovative actually. Instead of hunting for those osteoporosis diagnosis codes, which, as we said, are often missing, they shifted focus. They looked at the fracture costs directly.
Okay.
They identified the fractures first, and then they used published attribution rates. These are basically scientifically established probabilities.
Probabilities that link a certain type of fracture to osteoporosis.
Exactly. To estimate what percentage of those fractures were likely caused by osteoporosis, this way they got around that whole underdiagnosis problem pretty neatly.
That is clever. Look at the outcome of the fracture and work backward.
Right. But the real game changer, especially when looking at the burden for women, was their use of something called a Markov model.
A Markov model. Okay, sounds technical. What is that in simple terms?
Think of it like a simulation, a sophisticated one. It's what's called a state transition model. Basically, it maps out the natural history of osteoporosis for women, in this case, women aged 50 to 99.
Okay, natural history. So it tracks what typically happens over time.
Precisely. It follows groups or cohorts of women through different health states over one-year cycles. Are they healthy? Have they had a fracture? Or, sadly, have they passed away? By doing this year after year, it captures the long-term effects, the cascade of consequences, particularly for those really impactful hip and spine fractures.
Ah, I see. So it's not just a snapshot, it's projecting the ripple effects over years.
Exactly. And crucially, this allowed them to estimate costs for both prevalent fractures. Those are existing ones still incurring costs, and incident fractures. the new ones happening each year. Plus, it specifically accounts for those ongoing long-term care needs after a fracture, which, we already said were often missed.
That feels like a huge leap, moving from just counting codes to simulating these complex long-term pathways.
It really was. And they were smart about data integration, too. They blended Florida's own state-specific data, hospital records, population numbers, mortality rates with national data sources for things like outpatient care costs or long-term care incidence rates. They even used some UK data for excess mortality rates after hip fractures because good US-specific data wasn't available for that particular piece. It shows you got to be creative sometimes.
Resourceful data gathering.
Definitely. Now, it's important to know what they included and excluded. They counted direct medical costs, obviously, and direct non-medical costs, like, say, transportation needed because of a disability from the fracture. But, and this is key, they had to exclude indirect costs. Things like the value of unpaid caregiver time or lost work time for the patient or family members.
Why exclude those? They seem pretty significant.
They are. But the data just wasn't available to quantify them reliably. So even with this sophisticated model, the final cost estimates are actually quite conservative. The true total cost is likely higher.
Understood. So a very thorough method, but still likely an underestimate. Okay, so let's get to the results. What did this new, clearer map actually show for Florida, given its significant senior population? Even conservative numbers must have been impactful.
Oh, absolutely. The numbers are quite stark. Let's start with the base year 2000 snapshot. Back then, just in that 1 year, Florida saw nearly 86,500 osteoporotic fractures, the estimated cost. Almost $1.25 billion.
Wow, $1.25 billion just for fractures linked to osteoporosis in one state over 2 decades ago. That's a lot.
It really is. And digging into those numbers, hip fractures were the main driver. They accounted for over 2/3, about 68% of the related hospital admissions. And here is a critical point. Over 60% of those hip fracture patients were discharged directly to long-term care.
60%, so straight from the hospital to needing ongoing intensive support.
Exactly. It really underscores that the big cost isn't just the surgery or the hospital bed, it's the aftermath. Age-wise, the costs were heavily concentrated. People aged 75 and older accounted for, get this, about 75%, 3/4 of the total bill.
So heavily skewed towards the oldest residents.
Very much so. And when you look at where the money was spent, inpatient hospital costs were the biggest slice, about 56%. But long-term care, or LTC, was a huge chunk, too, 37%. Outpatient was only about 8%. This LTC share is actually higher than some older national estimates had shown, which likely reflected changing practices, trying to shorten hospital stays.
Pushing care into different settings.
Right. And gender played a huge role, too. Women accounted for about 75% of all those medical costs.
So, summing up 2000, older Floridians, especially women, bore the brunt, with hip fractures driving costs and a massive chunk of spending happening in long-term care after the hospital. That's the baseline. What did the crystal ball show for the future?
Okay, now fast forward to the projected burden for 2025. The model predicted quite a dramatic increase. The number of fractures was estimated to jump to over 151,000 per year.
Wow, from 86,500 to over 150,000.
Yeah, a 75% increase. And the cost, projected to hit $2.14 billion. Again, about a 72% increase from 2000.
Nearly doubling in just 25 years. That's a serious trend line for any health system.
It absolutely is.
Yeah.
Hip fractures were projected to increase by about 72%, spine fractures by even more, around 77%. Interestingly, though, spine fractures, while making up over half of all the fractures by number, they only accounted for about 8% of the costs, mostly because they're often treated outpatient, which is less expensive than a hip fracture hospital stay.
Got it. So volume versus cost per incident. What about the demographics in 2025? Did those patterns change?
They did, and this is where it gets really fascinating for planning. For women, total costs were projected to reach $1.6 billion. Huge number. But while white persons still made up the largest share of the total cost in 2025, their actual proportion of the cost was projected to fall quite a bit, from 87% down to 74%.
Interesting. So not fewer costs for them necessarily, but other groups growing faster.
Exactly that. Costs for Hispanic persons, for instance, were projected to increase 2.5 times over that period. Their share of the total cost burden was set to basically double, from about 8% to over 16%. And the group labeled other races showed the most explosive growth rate, projected to increase by 467%, going from 2% of cost to almost 6%.
Huge shifts. What does that tell us?
It tells us that the face of osteoporosis costs is changing alongside the state's demographics. It's not just about more cost, it's about who is incurring those costs, which has massive implications for targeted prevention, culturally sensitive care, resource allocation, you name it. It really paints a picture of future needs.
It certainly does. Those demographic projections are really eye-opening. Now, you mentioned the methodology was strong but conservative. Let's talk limitations. No study's perfect, right? What did the researchers themselves say they couldn't fully capture? And how might that change how we interpret these already huge numbers?
Right, that's a really important piece, understanding the caveats. And they were quite upfront about them. Interestingly, most limitations point towards the true costs being even higher than reported. First, as we touched on before, they had to exclude the cost of unpaid caregiver time. That's immense. Think about family members taking time off work, driving to appointments, providing daily help.
Yeah, the hidden burden on families, not captured in that $2.1 billion figure.
Not at all. Second, the study focused on people 50 and older. But osteoporosis can affect younger people, maybe due to certain medications like glucocorticoids, steroids. Those cases weren't included.
Okay, so missing some younger patients.
Correct. Another point. The inpatient costs were based only on fracture as the primary diagnosis. But sometimes, especially with spine fractures, someone might be in the hospital for something else, have a secondary osteoporosis-related fracture, and it extends their stay by days.
Adding costs that aren't directly labeled osteoporosis fracture.
Exactly. Some previous research suggested this could add another 20% or more to hospital costs, which this study couldn't fully account for. They also acknowledged they couldn't fully capture costs from non-fracture issues related to osteoporosis, like general frailty leading to nursing home admission, or problems caused by severe kyphosis that stooped posture putting pressure on organs. Real costs, but outside the fracture-centric model.
Okay, so multiple ways costs could be higher. What else?
Well, they made a conservative assumption about inflation. They assumed medical costs would rise basically in line with general inflation.
But medical costs usually rise faster, right?
They often do, yeah.
Yeah.
So projecting out to 2025 using just general inflation likely underestimates the actual dollar figure. Their own sensitivity analysis showed the projections were really sensitive to this inflation rate. Even small changes there could swing the 2025 cost by literally billions.
Billions. Wow. Okay.
And one last big one, the Markov model. That sophisticated simulation. It wasn't used for all fracture types or for men, mainly due to lack of the detailed incidence data needed to build it reliably for those groups.
So how are those costs estimated?
Mostly based on inpatient hospital data for those groups. But many fractures, like spine or wrist fractures, often don't lead to hospitalization, especially in women. And men's fractures were also likely underestimated.
So the model's power wasn't applied across the board, leading to likely underestimates for men and certain fracture types in women.
Precisely. So you put all these limitations together: unpaid care, under 50, secondary diagnoses, non-fracture costs, conservative inflation, limited model use. And the takeaway is clear. The $1.25 billion in 2000 and the $2.14 billion projected for 2025, as staggering as they are almost certainly an undercount of the true societal burden.
That really drives home the urgency. Even the conservative estimate is massive, and the reality is likely significantly more. Okay, let's try to wrap this up for everyone listening. What are the big final takeaways from digging into this Florida study? And what does it signal for health policy, maybe not just in Florida, but anywhere dealing with similar challenges?
I think the clearest takeaway is just how massive and frankly how rapidly growing the financial challenge of osteoporosis is. And crucially, that getting detailed state-level data using methods like this one is absolutely essential if we want to actually understand it and do something about it. This kind of analysis gives policymakers real granular information. It helps plan for future needs, like, okay, we know demand for long-term care is going to surge based on these fracture projections.
So it moves planning from guesswork to data-driven strategy.
Exactly. And it allows for targeting interventions. We saw those demographic shifts, right? The huge projected cost increase for Hispanic populations, for example. That screams, we need culturally appropriate prevention programs, tailored outreach, not just some generic campaign. It helps focus resources where they can have the biggest impact on curbing those future costs.
Using data to be smarter and more equitable about prevention and care.
Precisely. It really demonstrates the power of using data this way, moving beyond just reacting to problems and actually trying to anticipate and manage them proactively. And maybe the final thought to leave with you, the listener, is this. This study focused on the direct and some indirect medical costs. But what are the broader societal ripple effects if we don't adequately address this huge projected burden? Think about workforce participation, family stress, quality of life. And looking beyond osteoporosis, what other chronic conditions, especially those heavy on long-term care needs, could really benefit from this kind of deep dive predictive modeling at the state level? Imagine if your state had this kind of insight for conditions like dementia or diabetes complications, what could we achieve then?